Good afternoon. Thank you, Dr. Boral, for giving me this opportunity. My topic is my longest veer surgery, longest day due to masquerading sign. So there are two parts in this topic. My longest veer surgery, I'm showing one case, and longest day due to masquerading sign. I should say pseudo masquerading sign. I'm going to tell that. So the first case, it's a simple case of post-pseudophakic RD. I've started with an intention to finish it by 30-40 minutes. But one thing I came to know in 10 years of VR surgery, that nothing is simple in VR surgery. Even in plain and simple case can turn out to be like this. See, there is choroidal detachment started, and why? There is regression of the infusion cannula. This is suprachoroidal cannula. So the choroidal started. I swiftly came out from the port and just changed the infusion cannula. See how it is regress. The color changes. So without taking a second thought, I changed it, the normal cannula, normal 23 gauge cannula with a 6 mm cannula, which is available that time, and checked the infusion tip and started again doing vitrectomy. Going a little bit slow because one problem happened. Might be there is another problem, but I don't know what is there in my hand. So the vitrectomy, slowly I have started and PFCL given. I asked my assistant to decrease the pressure, and he suddenly decreased the pressure to 0. So this will create a negative suction inside the infusion port, and that will create this large iatrogenic break. So this is the second thing. I don't know how many still there. So see, a large piece of retina, torn retina came out. I slowly cauterized the edge of the iatrogenic break and started vitrectomy again. Oh my God, what are those things? Multiple torn retina came out, multiple torn retina. So it's a nightmare to me. This is the longest surgery, retina surgery I have done in my career, small career, but still it's a nightmare to every VR surgeon. So many complications in a single case. So I then started doing base excision slowly, more slowly. And once the base excision completed, fluid gas exchange started. Still, I am doing the residual vitreous cleaning. Now basic fluid gas exchange started. Retina is now settled. Now retina is settled. And the residual part is same in all cases. Want to dry up everything which is present, every bit of fluid present subretinally. Now I'm starting laser 360-degree barrage along with the barrage around the tear, primary tear and the secondary tears. Completed the laser, PFCL was taken out and silicone oil given. So it's a 30-40 minute surgery, turned out to be a 2 hours. So this is the post of 20/60 vision, but that is a nightmare. More adrenaline loss. This is my first case. And the second case is longest day due to masquerading sign. I should say pseudo masquerading sign because this patient around 65 years age with myelodysplastic syndrome had a history of platelet transfusion 3 times previously in the last 1 year. He had completed 3 cycles of chemotherapy and came with a vision of right eye 6, left eye 6/18, ERM with cataract. So I asked to go for cataract, but before that, everything, every lab test, whatever possible, I did that, and that is completed 2 weeks back. And patient took a date for after 2 weeks after completion of the test. So this is the case, cataract with ERM removal. So it's a simple phaco surgery. Lens removed. Cortical matter washed. Multiple IOL given in the bag. Then wash out the visco and the residual cortex. Okay, well placed IOL. Then started vitrectomy. It is also a plain and simple case. Just I have to remove the ERM and intend to remove the ILM also. So vitrectomy started. After 4 vitrectomy, I put triamcinolone inside the cavity. But the posterior hyaloid face is quite thick. So I give dye to remove the posterior hyaloid face and ERM first. The posterior hyaloid face removed very easily. Till that time, no problem. Remove the posterior hyaloid face. And now I'm trying to remove the epiretinal membrane. Bit by bit, I am removing. Just when I'm removing this part of epiretinal membrane, see, the complication starts. See, the bleeding start from here. So this is the, sorry, very sorry. This area, the bleeding starts and it increases. I remove the residual ERM as much as possible, increase the IOP, but the bleeding is still there. I tried to just push the clot away from the fovea, remove as much clotted blood as possible, and end the surgery with fluid gas exchange followed by C3F8. And I asked the patient in the table that whether he is taking any anti-platelet medication or something else. Nothing. So after surgery, during discharge, I asked the patient patient party to go for a platelet count next day. And to my utter surprise, that platelet count 65,000. So 2 weeks before I completed every test, that time the platelet count was 1,05,000. And the day after the surgery, it is 65,000. It's better in these cases of coagulopathy or blood coagulation disorders. We should do the test as nearest to the surgery date as possible. Thank you.